Good evening, everyone. Thanks so much for being here. Just bear with me a couple of minutes or a couple of seconds while I let my co-host in and give everyone a chance to filter through. But thanks so much for being here with me this evening. Perfect. Awesome. Okay. Welcome, Vishal.
Hi, Ben. It is lovely to be here, and thanks for inviting me.
You're so welcome. You're so welcome. I'm conscious of everyone's time, so people will continue to filter in, but let's kick things off. Welcome everyone to the next episode of Heidi Rounds. This one's a little bit different. Rather than focusing specifically on a new product feature, we actually wanted to spend a bit of time talking through research, data collection, and how we're validating Scribe and Heidi more broadly's impact in clinical practice. To do that, I'm very delighted to have Dr. Vishal Kapoor co-hosting with me this evening. Vishal, I'll let you introduce yourself and say hello to everyone.
Thanks, Ben. Hello, everyone. My name is, as Ben said, Vishal Kapoor, and I am a pediatrician at Queensland Children's Hospital. This is part of the Children's Health Queensland. For people who are interested, it's a quaternary hospital for pediatrics. And I was also till recently medical director, digital health for the Children's Health Queensland. I'm very glad to have been involved and honored to have been involved in a very interesting research project and AI Scribe implementation at Queensland Children's Hospital. And I was one of the leads for the implementation of AI Scribes at Queensland Children's Hospital and Children's Health Queensland. It's a pleasure to be here. Thank you.
Thanks, Vishal. Children's Health Queensland was the first hospital to roll out Heidi Scribe. So to say that you're a trailblazer is probably selling it short. But we're very grateful for your time this evening. I know you're on call as well, so thanks for being here. For those who don't know me, my name's Ben Condon. I'm the clinical director for ANZ, and very excited to take you through the session this evening. I want to start really by setting the scene and how we build transparently at Heidi. We know that being transparent with our impact and how we measure different data points is so important to building trust. We're then going to spend a lot of time talking to Vishal about his experience at Children's Health Queensland and the amazing peer-reviewed research that was published last month that we're really excited and really excited to see that now be out in the public after what's been more than 12 months of very hard work from Vishal and his team. I then want to pivot and change tact a little bit and talk about the Australian 2025 impact report that we released earlier this year. This was a report that we wanted to share the data that we were being held accountable towards, so that different organisations and clinicians could kind of understand the various different problems that Scribe could solve, but also, some of the challenges with even assessing Scribe's impact, which we can get into shortly. I'll then finish with a brief summary of how we're approaching research and future research opportunities for anyone that might be interested, and we'll end with a Q&A. In terms of questions, if you could just leave them in the chat, that would be fantastic, and we'll get to them at the end. So please just direct all your questions to the chat. In terms of our approach to being transparent with the data and the tools that we build at Heidi, we know that fundamentally that's the first pillar and that we have to build trust with not just clinicians but also patients and the community more broadly. And the way we measure impact and collect data for Heidi really it falls into three broad buckets. So we have de-identified platform data, so we can see a number of users, number of sessions, number of users using different product features that can give us signals as to what features are really valuable and what features in combination are adding even more value to clinicians' practice. We then have the deployments I spoke about that were captured in the impact report. Really, this is proof of value results. These are the results that hospitals and health systems are collecting when they're assessing Heidi to see if we're living up to the hype, so to speak, and delivering value for them in real clinical settings with staff that are on the job seeing patients, and certainly not a simulated environment. And then the final pillar, which is so important, but has a much more longer lead time, is the peer-reviewed research, which is where we work in partnership or sometimes just facilitate independent peer-reviewed research so that we can validate our claims in a more robust clinical trial setting. And I think we should start with that, Vishal. So I'd love to now talk about your approach to rolling out Heidi at Children's Health Queensland, because you not only rolled Heidi out across initially a few outpatient departments, but then a whole hospital, but also set up a clinical trial at the same time. So I'd love to start the conversation by asking you how you approach that, because it's a deployment is a big piece of work in and of itself, and so is a clinical trial.
Thanks, Ben. I think that one of the very key aspects was right from the beginning when we implemented the AI Scribe at Children's Health Queensland. We had a vision, and the vision was very clear. We wanted to see whether this amazing new technology could assist the clinicians in their day-to-day work, but at the same time, it was very important to ensure that we embedded research into it so that whatever experience we had was also peer-reviewed and had a research base so that we could share that with the rest of the community and lead to an overall improvement in a very logical and in a very robust manner. So I think that right from the beginning, that was our approach. We started small. It's difficult to undertake a project with thousands and thousands of clinicians. So I think that is one of the important parameters which helped us, because we did not go absolutely ballistic with, let's say, implementing it in 2,000 or 4,000 clinicians. We started with a cohort of, initially we anticipated around 100 clinicians. But then when we sent the expressions of interest out for the AI Scribe pilot project, that's what we called it. Initially, at that point in time, we had close to 150 expressions of interest. And finally, we had selected, and this was first come, first service kind of a basis, that we selected these clinicians, and ultimately 131 clinicians registered for this pilot. And simultaneously, we also, while we were embedding this technology, it takes time to set up something new like this, especially in the artificial intelligence space. So it also gave us time, couple of months while we were setting this up, to actually ensure that we looked at the research component and wrote a research protocol around at the same time, designed the study, consulted with a number of clinicians around the study design, and did the baseline work with the ethics, and looked at the literature, because we were keen to know that how it can impact and in what instances we'll find the benefit that can be utilized. So I think that these were the primers, the basis or the foundation of how we started our journey. We started small. We started with a proper governance framework. But at the same time, you would realize that in any setup, that when you are doing something like this, you have a couple of months while you're setting things up. And, we thought that research was possible and we had right set of people. So we were able to do it. So that sort of, sets the scene for some of the discussions that I can take you through as we go along.
And would it be fair to say that actually having that has spent that time to develop a research protocol actually made the assessment of Scribe easier for you in terms of you could have more conviction in the results that you were seeing, and that better made, I guess, helped you make a decision on a commercial basis, even to whether you wanted to proceed or expand that scribe usage across more of the hospital and health network?
Absolutely. I think that what we thought was we have to evaluate it anyway. So it was through a chief executive imagination fund that initially we had set up the whole pilot.
Mhm.
And at that point in time, we thought that we have to anyway do the evaluation. So it would be great if you could wrap research around it and do the evaluation with the research framework, which is exactly what we were going to do as an outcome evaluation, but we made it more robust. So you're absolutely right that that actually helped in getting very robust outcomes, which could stand the test of peer review and the rigor and robustness that is required for a peer-reviewed research.
Fantastic. Well, I might change slides and ask you to talk us through the study design and the key results, if that's okay.
Yeah, absolutely. So there were two key aspects to the study, and I would just take you back a step where we looked at the research governance aspects. See, artificial intelligence is so new. And even now, we were, I think, at that time, the first hospital, as you said, which were adopting it. So there was a lot of nerves and a lot of speculation and fear, and that how it will impact and whether it will be something which will be acceptable to clinicians and patients alike, etc. So one of the very important aspects was to look at the privacy impact assessments, the PIAs and ISRAPs with the digital health services. And there is something called FAIRA framework, which is in Queensland, and there'll be equivalent frameworks coming up in other states. And FAIRA stands for FAIRA, that is the Foundational AI Risk Assessment Framework. So those very elementary risk assessment and risk mitigation aspects were built into our implementation right at the base. And the great thing is that many other hospitals have actually used the initial assessments and the frameworks that we used and are exemplars to base the implementation in their hospitals. So that is one aspect, the risk and the clinical governance frameworks around the whole pilot project. And then there was the research governance aspects, which is pretty much standard from because there are already existing set of rules. So that's where I think that the foundational aspects were. Beyond that, the study design was a retrospective prospective cohort study design, which means that we looked at this cohort from the point of implementation. And going forward, we'll continue to evaluate the same cohort till 2 years. So the image that you see in the screen, which is our Journal of Pediatrics and Child Health article published in May, actually represents the 6-month evaluation. And currently, we are completing the 1-year evaluation of the same cohort. That is the key study design. And then we had a set of primary and secondary outcomes, and I can take you through them.
Yeah, that would be awesome. Before we jump into the key results, I should just say that QR code in the bottom of the screen will link you to the full text of the article for anyone that's watching. So I'll just give everyone a chance if they're interested to scan that QR code. But before we jump into the key results, and I know we've got one of the the primary outcomes on the screen already, but how did you approach measuring a baseline? We know a lot of organizations kind of come to us, and the first thing they ask is like, we don't have a baseline for documentation quality or for letter turnaround time. Like, how did you navigate that? And yeah, can you tell us a little bit more about that?
Absolutely. So we used a historical baseline. So the
Hmm.
same cohort's previous performance over the last 1 year was used as the baseline. So our primary outcome was uh, time to finalize the clinic letters. And that is from the time that people initiated the letter in the electronic system
Hmm.
um, to time that they signed it off as complete was taken as the time to finalize the clinic letter. And we used the historic time to finalize letters for the entire cohort for the last 1 year. Why we took the whole 1 year as, sorry, last 6 months, I apologize, because that was a 6 months evaluation, but for the 1 year evaluation, we'll be taking it 1 year. So exactly the same time period in the last year was used as the historical time frame for comparison. And just on that
Fantastic.
QR code, I just wanted to
Yeah.
mention that this is the whole article is free to
Yeah.
download, so it's open access.
Yeah. I should have mentioned that. Thanks for saying that as well. I have a feeling I know the answer to this question, but what was the result that surprised you the most? Having
Yeah, I think that the result which surprised us the most was the primary outcome itself. And that was the time to finalize outpatient letters decreased from a median of 7.9 days to a median of 14 minutes. What it means is that is the median is the 50th centile in that cohort of letters, and we are talking of letters in the tune of around 11,000 letters, both in the intervention period and a similar number, slightly lesser number, around 10% lesser number of letters in the historical period in the last year of the comparison. So it is a large number of letters, and in that, the median, which is why we use medians, was because it was a slightly skewed distribution. Median is the classical metric that we use, and that was amazing to see that it fell so much. And I initially we did not anticipate. We knew that it will decrease because people had this capability of now not sending the letters to the transcription team. And previously what was happening was that the letters were being sent to the transcription team. So someone dictated the letter, it went to the transcription team who typed the letter, went and came back to the person who would review the letter and sometimes send it back again because there is something that was not right. So there was 1 to 2 loops sometimes, and that loop you can imagine that would easily take 7 to 8 days. So when you look and consider that aspect, it becomes very clear. Okay. So it was almost taking that kind of a loop, and that loop went away for most of the letters because now the clinicians had this ability to basically finalize the letter from the Heidi output and copy and paste into the and finalize it on the electronic system, that it's just done and gone. So that transcription loop was no longer there. And when you think about that as it makes sense, yeah. But when it actually happened, it does take us with a surprise that we checked it a couple of times that it's actually real. So yeah, that was
yeah,
amazing.
no, that's it's awesome to hear, and I can imagine you get dizzy stuck in those transcription loops if you're sending it back and forth, and having that note done almost in real time is obviously a huge unlock. Um, I'm keen for you to be able to have some time to talk through some other really key outcomes from the study, and maybe let's start with the clinician other findings that kind of affect the clinicians in the cohort.
Absolutely. I think that one of the other very significant aspects, which I think will ring true to many other clinicians, is that there were lots of clinicians who were not able to cope up with the letters and the amount of letters which were being generated, especially in many of the surgical, especially, some specialties where the workload was really immense. They were really struggling to keep up with the letters. And that was significantly changed. And you can see that despite that decrease in the time to finalize letters, there were 10% more letters done per appointment in the intervention phase. And there were people who said that, oh, we were hardly able to do our letters, and now we are finishing all our letters. So we used something called triangulation, or a multiple metrics of confirming the same thing. So we have got the quantitative outcome as
Mhm.
the time to finalize letters decreased. And we know that the 10% increase was there in letters per appointment, but also this was confirmed through surveys. So when we surveyed people, and we also had focus group discussion as an outcome, and in some of those, qualitative metrics, it was very clear that people were doing letters when they were previously not able to do the letters. So that was very significant, I think, enabler, for the AI Scribe technology. Uh, and then we also did a survey of clinicians that what did they think about the quality of documentation. And um, there was significant response in with the fact that many clinicians actually felt that their documentation had actually improved. But overall, I would say that uh, the document quality was good. Um, and there I would like to say that, look, it's AI. We don't get it absolutely. This is one of the things that I want to highlight is that it does 95% of our job, which is amazing, right? It's someone sitting there and 95% of job is done. I'm happy to do that 5% later, just checking that there are no errors. Because guess what? What happens is that there is noise, there are children screaming, there is so much happening. And the AI scribe doesn't have eyes and it doesn't have voice recognition capability. So it is doing it all that magic with just the context. So I would be very kind to the AI scribe technology, and I ensure that if it is a noisy environment, I mean, we take full responsibility for checking the letters, and that is one of the things that we had embedded in our safety aspects. That every letter had every document which was in electronic medical records had a line which was there in the templates that the clinician takes full responsibility for checking the validity of the letters for the reasons that I have described. So I think that overall the quality of letters is good, and but it's that clinician has to take the responsibility of ensuring that the letter is correct, which we have to do even otherwise. For example, if it's my resident who is writing the letter, I would always check the letter. So it's just one of the same things, and but that is one of the things which we have to take that responsibility. Because technology may improve, but will I think that human factor is always to be there as an interface, as the gatekeeper to ensure that safety, security is not compromised and we are not putting anyone at risk. That's how I would put it. Um,
Absolutely. Absolutely. I think that's a
then,
really important point as well, because
yeah,
you think you've got the note there immediately after. It's you're able to review, and checking is already a part of a lot of particularly consultants work. And sometimes we get questioned on will clinicians review the note, and it's really great to hear. It's not just me that says that. We're already, as a consultant, you're already checking things. It's already part of your kind of clinical practice generally. So I think that's a huge insight. I've interrupted
absolutely.
you mid-flow.
No, 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 absolutely right. No, actually, you reminded me of a few instances because sometimes if there is a patient-facing document, I ask the patients to read it and say that, is this what, for example, the great thing is that we are able to generate letters so easily and patient-facing documentation. Just for the audience here who may or may not be aware, I would just give a command. I love prompt commands, by the way. And I would say that can we write, and some of these things can also be built into templates. So it's easy to build into templates. I'm more of a very impromptu person. So I would write a letter that can be, for example, write a patient explainer letter, which I think is now a Heidi default, which you can
Yeah.
easily generate. And I would give the letter to the parents and say that, can you read this and just, ensure that this is what your understanding is? So that we are all
Mm.
on the same page, and that is so great. Because at times the patients would say, but I did not understand this part, and that gives me an opportunity to then ensure that whatever communication is there, it's very transparent, and when the patients walk out, they walk out with the adequate amount of information, and also there are no ifs and buts and lingering doubts in their mind. So it's absolutely fantastic to be able to check, and I actually use some of this in patient communication. So it actually fits in really well, with that. And to tell you the truth, and this is something that I have experienced myself. When we used to send transcriptions, sometimes, um, we tend to mumble a bit. and or maybe the dictation is not, it's not picked up properly, and then we get this comment from the transcriptionist that we could not understand from 8 minutes 20 seconds to 8 minutes 25 seconds, and I listened to it and I said, gee, even I can't understand what I said.
Yeah.
But what happens is that in 8 days time or 14 days time, whatever it may be, you forget what you said. Right.
Yeah.
So sometimes, when it is done in real time, the memory recall bias is not there.
Yeah.
So that is another great thing, that, the missing pieces or some things which would have a memory recall bias issue with it get significantly reduced. And that is another very important aspect, which is really a great help. So I think
I
that
think
this
what,
is,
yeah.
sorry, you go, Ben.
No, no, I was just going to say, I think that also kind of highlights, like, not just is it easy to remember, but probably is a good segue into kind of thinking about the impact it had on your clinicians in the cohort and their experience of their work. You spoke to previously that a lot of them were struggling to cope with the sheer demand of letters and the volume that they need to get through. Busy quaternary centre. I'm getting flashbacks to my residency days. I can only imagine they'd be flat chat. How did your clinicians respond into the scribes' impact on their work life and their enjoyment of work generally?
Thanks for asking, Ben. This What we did was, we did a clinician survey within a month of implementation. So, and we considered the first month of use as the implementation when the clinicians are getting used. So it is from that time, in 1 month time, we did the survey of the clinicians, and we asked them number of questions regarding documentation efficiency. So that is a sort of a qualitative check on the quantitative numbers, that did they actually feel that the document efficiency was improved, and they felt that it was a significant. So you can see that it's written there, 83.1% reduced documentation finalization time. So that is not the quantitative aspect of it, because the quantitative aspect is the medians that we saw. This is basically them responding in the survey, that this is what they felt. And then above 80% said that there was improvement in the well-being. And we held the focus group discussions, which we are still analyzing some of the data. But that part comes very clearly, that there is significant feeling of well-being and improvement in work-life balance, and clinicians feel that the patient engagement is much better. So there is a lot of positivity in the clinicians, in the survey that we did and in the focus group discussions, which is currently being analyzed. Yeah, it is absolutely fantastic. Personally, I know of a clinician who has who has developed joint issues, etc. And the person is only able to actually do the letters because of the AI Scribe technology. So when people have injuries, etc., it's a lifesaver during those
That's
times.
fantastic. That's so good to hear. It's often you forget those human. I'm battling an injury myself at the moment, so you forget sometimes that can get in the way of you doing work. So it's awesome to hear. Um, the one group of people we haven't spent any time talking about is it's so important to also consider our patients. So love to hear what patients and parents of patients thought about Heidi during the trial as well.
So the patient's response was overwhelmingly positive, and uh, I think you can see on the screen, you've put those numbers there which talk for themselves. Like over 90% would welcome future use of AI Scribe. They were comfortable with using the AI Scribe, felt that clinicians were more focused on them rather than the note taking. You know how we used to work with the computers, and we are like typing and then looking here, and
Yeah,
the most of the time. So many a times, unless you're examining the patient, you're typing and you're spending almost 60% of your time just interacting with the computer, and 40% of times you're just moving like this. So it's
yeah.
almost like
Mm.
disengaged from the patient. And interestingly, when I was typing once, a patient said, "Should I go a bit slow?" So
Yeah.
even the patients are conscious that they have to talk a bit slow because the
Yeah.
poor doctor is not going to be able to write otherwise, you know. So it's so that part is gone. That is so good that I don't have to now focus on the computer. I can be free. It's
Yeah.
I am liberated
You can focus
from
on
the
the good
shackles.
stuff.
Yeah, exactly, exactly. So
Yeah.
I'm actually able to interact with my patients. It's such a relief. Um, and
Oh, it's
I
good to
can
hear.
tell you my personal anecdote that, sometimes we doctors don't realize how stressed we are. So, if you ask me, pre-AI Scribe era, that, Vishal, do you feel stressed when you go to the clinic? I said, no, I don't feel stressed. But it was only after I started using the AI Scribe that I actually realized that I was stressed because I felt a difference. Even while going
Yeah.
to the clinic, it was a very different feeling. It was like as if there was something heavy. I never knew that I carried that load. But
Yeah.
when I actually started using, so it was really significant. And even the patients, I feel that they can perceive that anxiety is not there in clicking, clacking the clinician. So the interaction is significantly improved with the patients, and you can see that in the patient responses. And our study had close to 333, I think, from memory, 333 patients who responded, and it was a overwhelmingly positive response.
It's it's awesome to hear, and I think that certainly I've lived that experience myself. You don't realize how stressed you are until that stress is taken away. But the number that stands out to me on that page is that 93.7% of patients felt that the clinician was less rushed. Now, I can imagine in a busy pediatric outpatients that, potentially screaming kids, siblings, like it's a pretty chaotic environment. So to have such a significant impact, I think is really, 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 really exciting.
And also that consider this, that when we ask the patients about, are you more comfortable? Do you think interaction was better? That is a two-way thing which they are sort of, experiencing. But this is more of they are even perceiving how the clinician is feeling, right? So
Mm.
they actually can perceive that the clinician is less rushed. The clinician, I think that there is a bit of transference of that lesser anxiety and a bit more comfortableness and more warmth in that interview, in that patient appointment, which I think is palpable to the patients also.
It's so, so important. And I think you're absolutely right. I think we all think we do a better job of hiding the stress that we're under. And in a
Yeah.
stressful environment, it's important to be able to be more present, which is really, really awesome to hear. Vishal, thank you so much for talking us through such a comprehensive study. And we're so looking forward to the 12-month results that are going to come out soon. I'm going to give you a break and I'm going to talk about the impact reports now, and we might come back for questions at the end. But that was awesome. And thanks again so much for your team's effort in pulling this paper together and really setting the standard for what this kind of robust assessment of a scribe in a clinical setting is really kind of been world leading in terms of its assessment of the outcomes of both clinicians and patients alike.
Thanks, Ben. It's a pleasure.
No worries. Now to pivot gears, another way we've tried to lead with transparency at Heidi is just by sharing the results that we're accountable to with our impact reports. And I'll just note there's a QR code to the Australian report, and now there's a 6-page version and a 20+ page version, so you can choose to read the more condensed version if you like. But the reason we did this was we found that despite being rolled out into over 10 different healthcare organizations in 2025, we were never actually asked or assessed on how scribes solve the same problem more than once. So every organization came to us with a very unique problem that they were looking to help solve. And those problems fell into 5 key buckets. So there was a bucket of documentation quality and safety, and recognizing that documents either weren't getting completed or were getting completed to a standard that wasn't satisfactory. There was a productivity and capacity point of view where they just simply needed to find a way to make their staff more effective. There was an integration usability piece in terms of just how do we incorporate technology into what seems to be complex workflows. And then there was the two things that we spent a little bit of time talking on with Vishal previously: workforce wellbeing, We know that more and more staff are leaving the profession or taking indefinite leave of absences, and hospitals are certainly feeling the pressure to try and make the work more sustainable from a workforce point of view. And then from a patient experience, trust and consent perspective, we had many organisations wanting to purely focus on if they can improve the patient experience, that gave them a competitive advantage in the market. So I'll go through the results for each of these domains broadly, and I haven't cherry-picked them. The reason they're not aggregated is because every organisation was assessed on slightly different combinations of these metrics, and they're not perfect. And the reason they're not perfect is not all these organisations had the resources to, say, set up a trial and do it as robustly as Children's Health Queensland. But certainly what they were looking for was a number that gave them the confidence to either proceed with and expand the use of Scribe, or go a different way. So it's in that context that we're not presenting these as definitive peer-reviewed results, but certainly these are the results that we've been accountable to throughout 2025. To give you the headline results, though, I guess we completed over 37 million consultations in Australia last year, and we had a median utilisation rate of over 86%. When we talk about utilisation, what we're talking about is clinicians using Scribe in more than 25 sessions a week. And why that's so important is when we talk about AI generally and Scribe specifically, and we talk about efficiency gains and productivity measures, and if that only happens if most clinicians use Scribe in most of their consultations. It doesn't work if they only use it for one or two consultations and then drop it and don't use it for the rest of their week. So that's a really important figure that we anchor upon and we measure in every deployment. And also, we were able to save clinicians on average over 9 hours per week, which speaks to the immediate relief that we've already spoken to in the previous section. But from a document quality point of view, the reason I asked Vishal such a leading question before about how did you baseline it is the first question we get often is, how do you baseline documentation quality across an organisation? It's not something that's typically assessed. The skeptic in me says, don't ask, don't tell. But I think it's a really difficult thing to measure. A short, concise note can be sometimes much more high quality than a quite verbose, lengthy note. So there are some ways, there are some different measures and matrices available in the literature, but we used a 5-point Likert scale for a qualitative assessment in one deployment, and we had 97% of respondents rate their final verified document as either good or excellent. There was also a neutral option, and there was no negatives, which was great. We took a median assessment across all deployments of 73% of clinicians reported that they felt that Heidi improved the quality of the medical record as a whole, not each note specifically, but 100% reported an improvement in the consistency of the medical record using Heidi, which was really pleasing because when you've got a consistency of record, it actually becomes easy to find the information you need, and you become more predictable to your peers in terms of your communication. From an integration usability perspective, I've already spoken to why the utilisation is so important, but importantly, we actually learned very early on that 68% of clinicians felt that the standard templates they were provided in one public hospital deployment actually didn't match their disciplinary preferences in a satisfactory way. So what we learned very quickly was that if we're too restrictive with the way notes look, actually clinicians will disengage and not use Scribe. So this is a really key insight for us because we're able to actually loosen the guardrails on this deployment and allow clinicians greater flexibility to adjust templates to suit their preferences. So maybe rather than using full sentences, they could revert to dot points and move around different sections as they saw fit. This actually increased their engagement with and utilisation of Scribe. So we're able to demonstrate that being less restrictive and being more open-minded to what that record or that final note looks like and allowing individual clinician preference was really, really powerful in terms of actually boosting the overall impact of the Scribe. There was one NDIS rollout that was really interesting because they actually tried both of, they did a split trial. They had a group of users using our free Scribe, which doesn't allow for customizations. and they had a group of users using our paid tier, which allows for fully customization of your notes and through templates. And what we were able to see is that those users on the paid customizable tier actually spent 39% more minutes on the platform compared to their components in the other group. And that completely eliminated all of their overtime, which is really, really exciting. The free group still saw an improvement or a reduction in their overtime, but it wasn't completely eliminated. And I think this really speaks to that previous lesson from regarding template customization is the more we allow clinicians and users to engage with the platform, make it their own, the more likely they are to use Heidi more often. And that's going to correlate to even more benefit in terms of efficiency, but also reduction in overtime and making their job more sustainable, which is really, really exciting. From a productivity and capacity point of view, in one public hospital, outpatient clinic and emergency department, over 13 weeks, we were able to save 54 clinicians 513 hours of overtime. That was baselined against the previous 13 weeks of the same cohort. That was then calculated as a notional overtime saving of over $128,000 in that time period for that pilot. And what was really exciting about this deployment is that more than paid for the trial and gave that hospital conviction that, okay, overtime is a bigger issue than perhaps we realized, but there is a solution here that we can scale rapidly across that organization. Similarly, in a different hospital, we're able to not quite get the same percentage reduction, but we're able to reduce overtime by 117 hours across outpatient clinics and EDs, which was still seen as a really significant result for a 12-week deployment. Workforce wellbeing point of view, we were able to show that Scribe not only saves time, but also 70% of clinicians reported a reduced cognitive load associated with that better decision making. And Vishal and I were talking about it before. You don't realize how stressed you are and how hard it is to retain everything in a busy clinic until you don't actually have to do that anymore. So that was really pleasing to kind of validate that and quantify that perceived reduction in cognitive load. We had 94% of clinicians report increased enjoyment of work, and that's so important. One, just from a keep looking after your staff point of view, but most importantly, I think happy clinicians make for happy people make for happy doctors and deliver better care. So it's really, really exciting. And I know I mentioned the overtime reduction on a previous slide, but that's also been used as a definitive measure for workforce wellbeing and sustainable work habits. And finally, we were able to show from a patient perspective, we had greater than 99% consent rate across all of our deployments. And specifically in the largest deployment of over nearly 4,000 patients, we had less than 20 patients decline Heidi in the session. So overwhelmingly, patients voted with their feet and were very happy to have their clinicians and their doctors use Heidi, which is one of the biggest concerns I think new clinicians and new users have is will my patients be comfortable? And that was really pleasing to validate that on such a significant scale. Patients also reported that they noticed improvements in perceived clinician empathy and trust, in addition to those findings that Vishal mentioned in his presentation. The final thing, and potentially my favorite finding, is that providing Heidi-generated patient explain letters improve trust and understanding of their condition, which is so important. I think we've released an impact report for the UK. There's a Canadian and a New Zealand one coming for very soon for last calendar year. And the reason we've done this really is to just show you how we're being assessed and the types of problems that Scribe can potentially solve across different organisations and healthcare settings. We're also hopeful that what it does is it gives you confidence to not have to necessarily try and validate documentation quality time and time again. We can move the needle and become more ambitious with how we're validating Scribes in different care settings. We've now validated very well in outpatient settings and emergency departments the impact Scribe has, and our next version of the impact report will be looking at inpatient settings, telehealth settings, and try and add to the visibility that we can provide the market and the public at large on how we're assessing Scribe. To pivot gears a little bit, I sense that many people online have got a keen interest in research, and we get approached a lot about different research opportunities. with Heidi, and I wanted to just spend a couple of minutes before we go to questions on how we're thinking about research at Heidi beyond potentially turning a deployment into a study. And research typically falls into three buckets when we talk about it at Heidi. So there's the research that is necessary for us to do from a regulatory and compliance point of view. These are studies that we run and we fund to validate the safety and to prove out from a regulatory perspective that our products are safe to go to market. So these are generally tightly controlled with when we have very specific partners that we do that with. But that bucket is the main focus, I guess, of our internal research team. There's a post-market surveillance bucket where we might not necessarily be trying to validate something from a compliance or regulatory point of view, but we want to add rigor to some of the claims that we make or to expand upon some of the findings of the impact report in a more robust way. So we will identify those things and look to partner with different organizations and universities to try and add rigor to those findings, the impact report, so that we can be confident that what we're saying stacks up in a research setting. And then the final one, which is the most exciting one, but the one that we don't talk about enough is independent research. So we essentially will support any research using Heidi any way we can. We don't have the capacity of a very small, very overworked research team internally. So really what this looks like is we can provide you compliance and security, privacy, all of the credentialing from an ethics proposal point of view. We can support you with access to the platform, and we can do kind of various things to help get the study off the ground. But this would be a study that you would run, you would write grants for, you would almost pitch us a study that you want to run with Heidi, and we would then enable you to do that in a very hands-off way so that you can have full autonomy over the study design, over the outcomes, and over the results. So before I hand over to questions, if there are any, I'd love to say if you've got a research idea in mind, if you want to set up a study, we'd love to hear from you. Please send me an email. My email's on the screen now, and I'd love to chat to you further about how we can actually get you to pitch to our team so that we can support independent study, because we're really bullish on the impact Heidi can have, and we really want to encourage people to test it in all sorts of environments in all sorts of different ways. And some of the independent research happening at the moment, I think there are 86 studies that are being run independently on Heidi right around the globe. It's really, really exciting, and we're really, really keen to facilitate that as much as possible. So yeah, please send through your ideas and your pitches, and I look forward to having my inbox flooded with ideas. I'm going to just check the chat now for questions. Bear with me while I just read a few of them. I think there's a great question here, Vishal. I might ask you that. What
Yeah.
are the ethical risks that you've identified and mitigated during the study?
I think that it was not just the study itself, it's anything that we do in the hospitals has to be taken with a lot of seriousness. So, because research is one aspect of it, but actually implementing something um, is is basically, taking a lot of responsibility. So, I think that how we approached the problem was we had a team which was multidisciplinary. So there was research elements to the team, but more importantly, much, much more importantly, we had a digital uh, we had digital health services um, who had taken on the project for implementation as a pilot project throughout CHQ. So there was a lot of investment initially on the privacy risk assessments, the impact assessments, the FAIRA framework was utilized, and I think that I can see in the chat that you have asked about AI ethics principle risks. So the FAIRA framework, which is Foundational Artificial Intelligence Risk Assessment Framework, it is a tool which has been developed by Queensland government, and it helps the agencies and departments to safely procure, evaluate, deploy AI solutions, and it translates the broad AI ethics into practical step-by-step governance. So having a governance framework like that, and it was very good because it was basically that framework came into being just as we were setting up the pilot project, and just prior to actually the project, a couple of months back, it came, and that helped to guide us. So I think that we had a risk mitigation. We went through all aspects of what risks could be involved, besides the privacy also, what the clinicians may land up into, what if scenarios. So everything was brainstormed prior to implementing the pilot. And then at the end of the day, there was this element that we were not using AI to make decisions, right? So that becomes much more riskier aspect when in those instances when we are doing implementation or research about AI tools which are actually making decisions or decision support. So we did not include any decision support aspects because that is potentially the next second or third step into how the AI evolves. So that is one aspect. We were asking clinicians to take responsibility for all the documentation. So it's like, the AI tool is doing stuff, but then I'm taking responsibility for everything that I'm signing off. So that part was implemented very rigorously. Then we also had patient safety aspects considered into it. For example, asking the patients appropriately about the risk, explaining to them. So we had a QR code for patients to refer to for details regarding what an AI scribe was, so that they knew what they were in, ensuring that we ensured that then the patients knew what AI scribe was doing, that it was not recording the information, it was only transcribing in real time what was being discussed. So the patient-facing aspect, the clinician-facing aspect, the clinician education, risk mitigation strategies, all were implemented side by side, keeping the broad Queensland-wide risk assessment frameworks with artificial intelligence into the mix. So that sort of, gives you a summary of what we did. What we did took almost 3 to 4 months. So I think we started in I think in March or even before that, and we were able to implement in November. So it took us good 6 months to go through all those steps rigorously before we could actually implement. So we were very thorough with that aspect, and thankfully we had a statewide framework to refer to. So I think that in a sense, I hope that I have answered that question regarding the AI
Yeah,
scribe,
yeah.
yeah, risk assessment and ethics aspects.
That's very comprehensive. Thanks, Vishal. I think to wrap up, James just asked a question about, what were the main procurement barriers that you faced, if any, and how did you overcome them in terms of, sounds like they've had a successful trial, but are keen to move forward and roll out more broadly. Did you have any barriers that you needed to overcome, or any advice that you could share with Jane to wrap up?
Yeah, absolutely. Look, procurement depends upon the public sector, private sector, what organization, the overall budget and financial aspects. So there is a lot which goes into procurement, and it depends upon the various aspects and priorities of a particular health service. So one of the things is advocacy is very important because the health services need to realize that how impactful something like an AI Scribe technology would be. And I hope that the research that we have done and some of the work that has gone through, not only us, but lots of other people who have done that work will help to provide you with that advocacy piece. The second aspect with the procurement always is the showing benefit. So I think that, as Ben said, that some of those benefits have already been shown, so that can be used. The main challenge for us was that we were the starting point, in the sense that we were one of the first hospitals to do it, and thankfully we had Chief Executive Imagination Fund to roll out the pilot. And most of the research that we did was practically on our own time. So, built that into it for a robust procurement evaluations or a robust evaluation framework, which really helps because when you want to procure something for an ongoing business, you need to show that there is actually a return on the investment. So that return on the investment is very important. But you can draw on some of the existing literature from Australia now that saying that there is certainly return on investment on these particular aspects and help with that procurement piece. Um I think that that was the main thing, that there were some enablers in funding, but then for an ongoing business case, I think that our research and the robust outcome evaluation framework really helped, which I think will also help others.
Fantastic. Um, Vishal, thank you so much again for your time and for stepping off while you're on call to talk us through it. It's been a wonderful conversation and just so grateful for the work that you did in putting that study together and for sharing your wisdom with us this evening. It's been fantastic. Thank you to everyone who's come on and spent an hour with us this evening. I hope you enjoyed it. I hope you found it insightful, and the email's there again if you have a research idea that you'd love to pitch us. So thanks so much for your time. Thanks again, Vishal, and good night, everyone.
Thanks, Ben, and thanks, everyone. Have a nice evening.